As is already explained, known to everybody now, there is some confusion about the program. So never mind. I have got maybe 1 or 2 points, but we'll quickly go through and may we keep some time for the discussion. That will be more interesting. As you know that HepPIF is a heterogeneous syndrome, and major clinical trials failed to reduce mortality or improve clinical outcomes of any agent excepting the very recent empagliflozin and maybe in next year dapagliflozin. This failure to find a single therapy is due to the marked heterogeneity. And what is the latest guideline this year from European Society for HFrEF treatment? Diuretics are recommended in congested patients with HFpEF in order to alleviate symptoms and signs. And by diuretic, perhaps it's conventionally taken as loop diuretics because that is the mainstay of treatment. Though no clinical improvement, no mortality benefit, but clinical improvement, and that is the only class 1 indication. Why there is so disparity? Because there are 4 different types, at least 4, if not 6 different types of HFpEF. Hypertension is the common denominator. Some are obese metabolic syndrome, some are ischemic heart disease, some are frail elderly patients, and some have got atrial fibrillation and pulmonary hypertension. Now, if we stratify this according to the etiology, you will see the pulmonary hypertension right heart failure group with HFpEF, they require aggressive diuretic. The cardiometabolic syndromes as well as the high output states, they require diuretic. If you go by the clinical presentation, exercise-induced filling pressure, no role of diuretic. Right heart failure, HFpEF, aggressive diuresis. You see, here is the subgroup which requires so much of diuresis, and volume overloaded, any people, whatever be the type, if he is volume overloaded, then spironolactone is the drug of choice. If you see this overweight group, if you get lung congestion in your clinic, if you find basal crepes, if you see that neck vein is engorged, then along with the loop diuretic is loop diuretic, you also add spironolactone. What is the role? And the Silverman has determined in 2 years ago, there's a very nice article which showed what is the role of mineralocorticoid receptor antagonist in HFpEF. Spironolactone is a mainstay of treatment in HFpEF and should be considered in all patients. Who are these patients? 3 groups with high BNP, number 1 group, number 2, prior history of heart failure hospitalization, and number 3, evidence of volume overload. So these are the 3 category of patients in your clinic with HFpEF whom you consider a mineralocorticoid antagonist. But what the top trial told us, as Dr. Jain has so adequately explained in 2014, the last line, in patient with HFpEF, treatment with spironolactone did not significantly reduce the incidence of primary composite outcome. What are these composite outcome? Death from cardiovascular cause, aborted cardiac arrest, or hospitalization for management of heart failure. So cardiovascular death, heart failure hospitalization. There was no parameter of symptomatic improvement. Now, as he has shown, there is no difference with the primary endpoint, no difference in cardiovascular death, but you see the left panel, there is a p-value 0.04, that means significant difference in heart failure hospitalization, particularly first heart failure hospitalization. But overall death, again, there is no difference. So there was some observation made by Deepak Bhatt subsequent to this, that patients were generally older with a relatively preserved kidney and acceptable potassium. When considering the constituent component of the primary endpoint, only heart failure hospitalization was reduced by around 17%. P-value was 0.04, while hyperkalemia are more prevalent in spironolactone arm, 9% versus 18%, but this did not translate into clinical adverse events, including need for dialysis or hyperkalemia-related death. So that is a bit reassuring, though hyperkalemia is quite anticipated, but perhaps it was not so harmful. There were a few post-hoc analyses, as 28% of patients were included or recruited by elevated NP. And this group of patients who are recruited on the basis of high NP had a 35% reduction in primary endpoint. This benefit was not observed among patients who entered the trial on a basis of heart failure hospitalization history. So if you see about 71% of patients were included by heart failure hospitalization, where you did not show any benefit, but about 30% of patients who were admitted for high NT-BNP, there you get the benefit. So naturally the question comes, if we recruit all patients on the basis of high NT-proBNP, perhaps we could show the huge benefit of spironolactone. But again, that is open to question. Now, another post-hoc analysis showed there's a marked difference in baseline demography. As Dr. Jain has highlighted, that Russia and Georgia patients were not given the proper treatment all the time, which were so obvious in our very famous ticagrelor trial, Plato trial. You see, all the benefit came of ticagrelor in the Russia and Georgia. There was no benefit in America. Here, just the opposite. The observed geographic variation analysis demonstrated a 15% relative risk reduction in primary endpoint favoring spironolactone in patients enrolled in America rather than in Russia and Georgia. So now it's up to you to accept which country or which country's system you rely more. And then if you rely on American thing, then perhaps you will see that spironolactone is good. If you think Russia and Georgia are more authentic, then you will see, perhaps say that spironolactone is no good. Now, also, you see that third point, that depending on phenotype, as I mentioned, phenotype is so very important in HepPEP management. There is a huge difference of all the parameters if you classify them as their phenotype. You see, all-cause hospitalization, it varies from 45% to 20%. You see the hospitalization depending on phenotype, non-severe hospitalization, everything depends on your phenotype. So phenotype is very important. And as I mentioned, congested patients on metabolic syndrome, patient on with NT-high pro-BNP, they will have benefit. Now, what about the interaction of atrial fibrillation? In TopCat showed about 30% patients were in atrial fibrillation, and they were at very higher risk than non-atrial fibrillation patient. But spironolactone did not have any interaction between the two groups of AF and non-AF. So really AF does not change your management policy. And if you see, no AF, history of AF and AFR enrollment did not have any significant p-value, excepting the number of patients who are not on AF at the beginning but developed AF during the study. There are some sex difference. In TopCat, women and men presented with different clinical profiles. Women were more old, they had more pulmonary obesity type of thing, diabetes. But the interaction between the spironolactone and sex in TopCat overall, and in the present analysis, well, this analysis came, you see, in the JACC very recently, was non-significant for the primary outcome. But there was a reduction in all-cause mortality with spironolactone in the females. So again, this is a food for thought, whether your female patients, you will be more proactive to give spironolactone because there is a hint of benefit of mortality in female patients. And we nowadays knows that a lot of HepPEP patients are amyloid. So does amyloid interact with spironolactone? Among 590 patients with detailed echocardiographic data proved amyloid, these patients had the worst prognosis among the whole enrolled patients of TopCat. But again, like atrial fibrillation, spironolactone has got nothing to do. They did not interact whether the patient was amyloid HepPEF or non-amyloid HepPEF. My friends, in 2016, there was a meta-analysis came which concluded that MRAs reduce the risk of adverse cardiac events in HepRef, but not HepPEF. MRA use in HepPEF increases the risk of harm from hyperkalemia and gynecomastia. Selective MRA, like eplerenone, are equally effective as non-selective MRA like spironolactone without the bane of gynecomastia. On the top that we can conclude that spironolactone is not superior to cardiovascular outcome. Majority of these patients were already on RAS blockade. So this is very important. Without RAS, whether mineralocorticoid antagonist solely could have benefited, as Dr. Jain mentioned, in the fibrosis and remodeling process, we do not know, because most of the job has already been done by ACE inhibitor ARB. So we could not find perhaps the incremental benefit. So in the patients who cannot tolerate ACE inhibitor or ARP. Can we give MRA with benefit? Again, open to question. There was also a significantly higher rate of hyperkalemia and renal failure, but it did not translate into clinical event. The reduction of heart failure hospitalization was good, but it deserves further study as it is not a primary endpoint. Similarly, a reduction in mortality in women in hypothesis generating and again deserves further study. So my friends, my parting comments are, HepPEF has been notoriously resistant to treatment. No single agent has been identified as being effective in improving the outcome. Current recommendations support only the underlying etiology and decongest the patient with proper diuresis. The current findings do not support a role of MRA in this patient, not particularly as a diuretic. MRA we do not use as a diuretic so often. Heterogeneity among patients may have impacted the result. I stop over here.
Thank you very much. And two good talks, very good talks. And what we can, definitely conclude, draw out of these two talks is the fact that for symptomatic relief, as for HFrEF also, we can use the diuretics for symptomatic relief. That's a standard accepted, and that is the loop diuretics we can use for symptomatic relief. And for long term, there are specific groups wherein we can use aldosterone. We should, however, be also aware that we have very good new drugs on the anvil. I thought either of you guys would have talked about Fibrillation trial, which has been done using finerenone. And of course, there is an element of CKD and diabetes in that. But those were, again, patients where primary endpoint was reduced. So we've got exciting things happening on that front.